of our Open Disclosure Webinar series. And I hope you can all hear me and see the slides this morning. We're very excited to introduce you to our speaker today, Dr. Leona Dann, who is calling in from New Zealand. And she will be here to speak to us about partnering with consumers and to learn and heal and improve from harm events. And as you will have noticed, I avoided trying to pronounce because I don't want to offend. But I'm very excited to learn more about the culture and the cultural approach taken in New Zealand in relation to harm events. So I'm not doing that from a place of judgment or reservation for any other reason than I want to actually show respect to the language and the culture. And I'm excited to learn how to pronounce all of these pieces of language and tradition and custom. So as I say, welcome to the webinar. I'm just going to open with some of our usual housekeeping pieces. We'll be starting in a few minutes. Just to note, you are all automatically muted and will remain on mute throughout the webinar because we use the chat box so as not to interrupt our presentation. But please do engage through the chat box, and we ask that you take a moment to introduce yourself there. It's always fabulous to see where our audience is dialing in from and from what organization. So please do feel welcome and free to do that. And also in the chat box, you'll find information both related to the presentation, but also related to audio and technological issues if we encounter those. So this information will be replicated in the chat box, so do not fear if you suddenly encounter interruption to your connectivity, your audio. You may want to dial in where you can still receive the audio. Sometimes we find individuals benefit from watching the webinar but receiving their audio through their phone. So just consider that, as I say, if you have any connectivity issues. As usual, we do have CPD points on offer for our webinar, and this only applies when you watch the webinar live. So you'll only have them if you're staying tuned in here this morning, Thursday, 20th of November, not if you're watching this on YouTube at a later date. The NIMBY points are available from today, and we're working with our colleagues in our CPI to secure the points for medics. And please do use our shared inbox there to apply for those. Unfortunately, all the Irish Sign Language interpreters were fully booked for this morning's presentation. However, closed captions are available, and you can find these through the details that are pictured here. And I hope that is support for those who have need accessibility supports. So I won't linger any longer. As I say, do check the chat box if you need any support throughout the webinar and ask us any questions there. Without further ado, I'm delighted, as it says, to welcome our presenter for today, Dr. Leona Dann, who is a registered nurse and midwife with a master's in midwifery and a doctorate in health science and a postgraduate certificate in ergonomics and human factors. She was the lead maternity care midwife and also has worked in various leadership positions in midwifery nationally. And her areas of interest include human factors and learning through understanding the lived experience. So without further ado, I will hand over to her, and she's going to introduce us to our first piece of cultural inspiration, if I may say, through Turkey. Thank you so much.
Well done, Ellie. Thank you. So this is, it's culturally the right thing to do in Aotearoa, New Zealand, when we start a meeting or a gathering, that we always have a karakia to open, so to clear our minds and prepare ourselves for the most opportunity there is. And then I will close at the very end with the closing karakia. So, karakia timatanga. I will say it in Te Ao Māori and you can follow along in English. E te hungia whai, te mataranga kia marama. Unahia, te anipa, te nuha, kia mahia. Kia whai take nā mahi katoa, tū maia, tū kaha, aroa atu, aroa mai, tātou ia tātou katoa. Hui tae kie. So thank you for that and for letting me share the karakia with you. I'm now going to share my screen, and you know we do this in the practice and it always works really well, so fingers crossed it'll be just the same now. So bear with me for a moment while I make sure I share with my audio. Right. Can I just double check, Kelly, is it all good? Can you see? Oh good, Lorraine, thank you. Okay, very good.
Thanks, Leona.
All right. So, good morning to you in Ireland from a very end of the day over here in Aotearoa, New Zealand. And it's just such an opportunity to come today and share with you this morning. I just have to say that I have had the wonderful pleasure of working with many Irish people over my nursing and midwifery years. In fact, my community midwife in England when I trained was Irish, so I feel a little bit like I can connect. So thank you for having me today. It's always positive, I think, to share and learn from each other across the system and across the world. So I hope today will be interesting for you and there'll be something that you take away for your work. So let me just make sure my slides move on. So today I'm going to cover these 4 areas for you. So I'm going to provide a brief outline of New Zealand because I think it's important for you to understand the context within which we work. A background on our adverse event reporting in New Zealand, introduce you to our healing, learning and improving from harm policy, and describe why consumer and whānau engagement is essential. And the Health Quality and Safety Commission, so the commission where I work, promotes consumer engagement as a critical component of system or patient safety and system improvement. By involving those who have experienced harm, healthcare providers have the opportunity to gain valuable insights into what occurred and how future harm can potentially be prevented. This approach aligns with the Commission's broader mandate to improve health quality and safety across New Zealand healthcare. And this presentation will also highlight perhaps some opportunities for us and for Ireland to align some of its patient safety practices, perhaps with some of what we do, and to foster some international collaboration together. So let's just think about the context. Here we are on the globe, this tiny little slither of orange on the bottom of the globe, that's Aotearoa, New Zealand, near the bigger landmass to the left, which is Australia. Often people put us together and want us to be another state of Australia. In fact, when I developed this image through AI, it kept wanting to colour Australia and New Zealand as orange. But we are not a state of Australia. We are our own country, our own unique space and our own Indigenous population. So talking of the population, we're made up of 5 million people. Around 68% identify as having European ethnicity, nearly 18% identify as Maori, which are our Indigenous population, 17% is Asian, which demonstrates over the last few decades how Asian people have been moving to Aotearoa, New Zealand. Nearly 9% is Pacifica, and you can see there, nearly 2% are Middle Eastern, Latin American and African. But one of the things that's really important for you to understand is the Te Tiriti o Waitangi. So this is the treaty. This was signed in February 1840 and it's a foundational document in New Zealand that established the partnership between Maori chiefs and the British Crown. And this has shaped the country's legal and social landscape ever since. The health and disability organisations in New Zealand have a responsibility to meet the obligations of the treaty as a foundation of achieving Maori health and aspirations and equity for Māori. The Hauora report, which was a report that was done in 2019 which looked at the health and well-being of Māori underpinned by the treaty, recommended these principles needed to be followed in order to provide a framework of how we can meet the obligations of Te Tiriti in our day-to-day healthcare provision. So tēnā rangatira is one of the principles, and this provides Māori self-determination and mana mutahaki in the design, the delivery and the monitoring of health. And the principle of equity requires the Crown to commit to achieving equitable health outcomes for Māori. Active protection requires the Crown to act to the fullest extent practicable to achieve equitable health outcomes for Māori, and this includes ensuring that its agents, such as the Commission where I work, and its treaty partner are well informed. Options, the principle of options requires the Crown to provide for and properly resource kaupapa Māori health and disability services, and that Māori are involved in partnering in developing care. And partnership requires the Crown and Māori to work in partnership in governance, in disability service design, and monitoring of health outcomes. So these principles are really important, that you just have an understanding that they exist, and that they have informed how we engage with consumers in our healing, learning and improving from harm policy. Which is a segue into me describing who I work for. So I work for the Health, Quality and Safety Commission, Te Tāhū Hauora. We call ourselves the Commission. We've been around for a while now, since 2010. And we, I think, have a really wonderful position in that we are independent. And so we work alongside health agencies. We're not bound by contractual arrangements. And I think that enables us to work in much more of a relational way. Like the wider public health sector, and I think probably like what's been going in Ireland over recent times, we went through a big realignment and restructure last year, but throughout all of that process we've remained focused on being an independent voice for the health system and delivering value for all New Zealanders as best as we can. So there are a couple of standards that underpin how we engage with consumers. So review of the previous standard, the Ngā Paereira standard on the left of the screen, the Ngā Paereira standard Health and Disability came into effect in February 22. And this standard includes a wide range of providers. Historically, the standard of what people would be able to access was around hospital care, but now it's much broader than that. It includes a lot of community resources such as primary birthing services, hospice care, aged residential care. So a large amount of people now have to abide by or demonstrate how they meet these standards. And the standards refer to both the Commission's clinical governance framework and our healing, learning and improving from harm policy. So whilst we are not a regulator, these standards enable the provision of the policy to be enacted within the health and disability sector. On the right of the screen is the Royal New Zealand College of General Practitioners. They have their own foundational standards. They also have our clinical governance framework in there, and they are working through implementing our policy at the moment. And there's a few legislations that are important for you to understand. So the Hauora Healthy Futures Act, that came into being after the 2019 review from Te Tiriti on health for Māori, and this has reformed our health system since it came into being in 2022. It's got a vision of a health system where people live longer, in good health, have improved quality of life, and there's equity between the groups that I demonstrated our population to be. It is intended that we build a healthcare system that works collectively and cohesively around a shared set of values and a culture that enables everyone to bring their very best to work and to feel proud of what they do when they go home. The Act required the Commission to develop a code of engagement with consumers, and I will come to that a little bit later. Then we have the Health and Disability Commission, so that's up on the right of your screen. The HDC, we call that for short, came into being in 1994 after an obstetric gynecologist performed some research, shall we say, without women's consent regarding cancer in situ in the cervix. As a result of that and the consequences to those women, the HDC came into being, and their being now means that there is a code of rights for the rights that consumers have when they access healthcare in New Zealand. So whilst that is great, it does mean that that was developed 30 years ago, and it does tend to look at breaches against those rights, which means it's a little bit like focusing on a bad apple and the breach of the act, and doesn't necessarily align now with how we think about complexity and systems thinking and moving away from blaming people for what they did or didn't do, but much rather understanding how the system's designed that means people make the decisions at the time that they do. So there's a little bit of tension there between that and the work that we do. And finally, in this legislation part, I just want to bring your attention to the ACC legislation. So the Accident Compensation Act came into being in 2001, a key piece of legislation in New Zealand because it established a no-fault compensation for personal injuries. This means that if someone injures themselves in an accident, or if they have a treatment injury while they access healthcare, they can receive compensation without needing to prove fault or negligence on behalf of the other party. So this is really important because what this does is it moves us away from being a litigious society. The bar for suing me for not providing midwifery care or suggesting I did or didn't provide midwifery care is so high that I think it means it's better and easier in a way for us to engage with consumers and whānau as health professionals when we review harm. So quite a different legislation in this country, which I think is really important for you to understand. So as I said a little earlier, the Hauora that came in said that the Commission had to develop a code of expectations for engagement with consumers and whānau. So we developed the code. This is a little piece of it on your screen, and you can download that from the internet if you want to. But this code was developed in order to support health entities and how they do engage with consumers. And they have to report against this every year. So it's not necessarily just about how you plan care with the consumer, but it's around how we do not design any new health services without using co-design with our consumers, with the end users, how we have consumers involved in harm events, how we have consumers involved in clinical governance, for example. So this is a really important code. It does not replace the HDC Code of Rights, but in fact they kind of support each other with how they support consumers and engaging with them. So the Code of Engagement is also part of the Collaborating for Quality framework for clinical governance. So this is our framework for clinical governance we released last November, so a year ago already. It replaced an earlier version in 2017. And this framework really focuses on the importance of everyone having a role in clinical governance. So it's not just because you're a director of midwifery or you have a leadership title that you're involved in clinical governance. Everybody has a responsibility. It also focuses on what we call nested governance, which says that in every different health and disability service provider, there should be clinical governance around that practice, that service, but that needs to have an escalation process and a really clear pathway of sharing information through to regional and national clinical governance so that we can all work together in our constant idea of improving the quality of care that we provide. So within the clinical governance, there are 4 domains, but for the purpose of our time this morning, I'm just bringing your attention to the domain at the top, which is that consumers and whānau are partners in healthcare. So this is around the health needs and expectations of consumers that they should be incorporated into service design and delivery so that care is clinically and culturally safe. And this requires trust and transparency and a willingness to share from each other. And I think you can hear there's connections to that code of engagement I just presented in how I've described this domain. You can see that there are 3 other domains here, and these domains and the subsequent 4 drivers that support the domains also include the importance of relationships with consumers, and that consumers in whānau have involvement in clinical governance throughout all of the domains, and that they should be able to describe what's important care for that community, where they live, what their needs are, so it can be specifically meeting the community needs. So this governance framework is really closely linked to and supports the Code of Engagement, and hence my bringing your attention to it today. Please do feel free to download the governance framework if you want to have a little bit more information. But let's bring us now into the real focus around harm events, which used to be referred to as adverse events. So let's have a little brief history of that. So in 2012, the Commission released its first adverse events policy. And I remember that really clearly. I was a director of midwifery at the time, and we went to a 2-day event introducing the policy and how we were needing to report to the Commission any adverse events that were SAC 1 or 2, so Severity Assessment Code 1 or 2. And then we were taught how to do root cause analysis. Root cause analysis, a methodology that was appropriate at the time, and we were really thinking about it being a complicated health system, and therefore really open to analysis and breaking down and finding what were the key elements there that could be fixed and would help prevent harm in the future. Then we reviewed that policy in 2017, and we had an increased impetus then on engaging the consumer through open disclosure. And we introduced different methodologies because we were becoming more aware that the health system was moving away from being complicated and was becoming much more complex. We were really starting to understand and to look at systems thinking and to think about complexity, and to start to understand that maybe we weren't making the change in patient safety that we'd wanted to because of perhaps how we were reviewing harm, and we weren't understanding that complexity. Then in 2019, we got Dr Leona Dann to produce a research project on understanding why we had really low adverse event reporting for Māori. And that's the image on the screen. You can also download that. So this transpired to be that we were looking at harm from purely a physical lens, and that from a Te Ao Māori perspective, harm is much broader than that. And so we learned a lot from that, and that really helped inform the policy here in 2023 that we developed. So this was the release of the Healing, Learning and Improving from Harm policy. And we've moved away and started to really change and shape our language as well, to move away from words that can cause more unintended harm to people. So we don't call it adverse events now, we call it harm events, to be much more inclusive of harm that encapsulates spiritual and cultural harm as well. So let's think about that for a moment. So when we were looking at the 2023 policy and we were working to develop that, we looked at and received extensive feedback and evaluation of other definitions. We looked at the international literature, and we did define harm, but we also defined harm as having individual components. So now we say that harm can be physical, but it's also psychological, potentially cultural, and potentially spiritual, and maybe all of them. And so we need to be really aware from a Te Ao Māori perspective, but also from anyone's worldview, that these forms of harm are really important and need to be considered. And so the policy includes these types of harm. So the policy came into effect in July 2023, and it reflects our commitment to being relational rather than risk-focused reviewing. It aims to heal, to learn, and to improve through meaningful consumer involvement. It's developed using co-design, and we had 2 chairs. The co-chairs, one chair was from the Commission, the other co-chair is consumer, and she is Māori. and it reflected our commitment to consumer engagement and our partnership approach and the principles of te tiriti. As you now know, engaging consumers in harm event reviews is both an ethical and a legal imperative, and this policy embeds restorative practice and te tiriti a waitangi principles, and cultural responsiveness is central to our approach, ensuring that Māori worldviews and practices are respected. You might note here that we've moved from, these are our 8 principles, but we've moved from open disclosure in 2017 to now open communication. And we now have a new principle about restorative practice, and I've bolded those because I'm now going to talk about those in a little more detail for you. But firstly, I'm going to give you a break from my talking and play you a short video that introduces you to our policy.
Tēnā koutou, ko ahau, ko panikiri te maunga, ko waikari moana te moana, ko waikari tāheke te awa, ko ngā tiruapani te iwi, ko ahau, ko te wai mātau. Nō reira, tēnā tātou katoa. My name is Angie Smith, and the reason why I got involved particularly with the Health Quality Safety Commission work was in 2017, my mother had a stroke. And that, I think, was the start of my journey through this health journey, was advocating for my mum and advocating around the appropriateness of the treatment and the rehabilitation, because it was about Te Reo Māori was really important to my mum and her recovery, and yet there were no staff speaking a language that she is more comfortable with. So the importance of allowing whānau members to be by her in those moments when she was really vulnerable, and having that language, needing to be there to translate for my mum, was important. So it is really important from a Te Ao Māori worldview that we build a relationship with whānau, we build a relationship with consumers, we build a relationship with even our healthcare workers. Because if there's no trust, then the whānau won't come forward. The whānau will be hurt. The whānau would not know how to get help. And it leads to more unnecessary harm, trauma, unnecessary deaths.
In complex systems like healthcare, it's very likely that under some conditions things come together in really unexpected ways, and harm can result from that. And so it's really important that we understand that harm is something we should try and reduce, but it's something that's part of our everyday. It's about how do we manage risk to try and prevent harm. So because we can't entirely get rid of those risks, it means that we have to find ways of engaging families when harm occurs. It's not about saying these things are inevitable, or that's just one of those things. It's about making sure that we, front and centre, focus on how do we understand the experience of harm and support patients, their families, but also the staff involved when they're affected by these events. So the big changes in the new Healing, Learning and Improving policy are really focused on making sure that we meet the needs of all those who are harmed or affected by an event. So that's patients, their families, but also the staff involved, and making sure we deal with that. The second aspect is really focusing on system learning. So trying to understand what was going on for the people involved at the time. Why did their behaviour make sense? What's so normal about this event, and what does it tell us about the trade-offs or constraints or risks within our systems, and using that to then improve our systems to make care better all the time. And I think we all have a part to play in that. We can be involved in telling our stories about what was going on at the time of the event. We can be involved in thinking about what does this tell us about our systems, and we can be involved in trying to understand the experiences of patients and families and work to restore those relationships. This is a policy that affects everyone in healthcare, and so I think it's really important to go away and look at the policy and then to understand what are your local processes and how can we all be part of healing, learning and improving from harm.
I hope that was helpful and just gave you a little bit more knowledge around the policy. So yes, our move from open disclosure to open communication. So we changed the principle because we felt that whilst open disclosure is essential and is a part of open communication, the greater the open communication is, the more significant the reduction in emotional responses and negative responses to harm events for the consumer and their whānau. So when I say whānau, just to clarify, refers to their immediate family, but also their wider family. So in a Māori worldview, family is much greater than your immediate family, if that makes sense. And we also know that open communication will enable support for the consumer and their whānau over a longer term than just at that actual moment of disclosure. And it allows the consumer and whānau experience to inform the review and to offer improvement depending on whether the whānau wants to do that. That's part of having their needs met. And sometimes they do not want to be engaged in a review process, but then sometimes they change their minds. What matters is that they have a key contact to come back to should they change their mind as well. So even if they say no to begin with, then sometimes that does change, and that has been my experience as well. So open communication refers to the timely and transparent approach to communicating when harm has occurred, and that aligns with Right 6 of the HDC Code of Rights. And a key step to a relational response is open communication and an approach to understanding the experience of people harmed, so really understanding that lived experience. And by using open communication and that dialogue that can happen throughout a review, it should maintain or restore the tapu or dignity of all the people that were involved. So as Carl said, this isn't just about our consumers and their whānau, but also around our health workforce. And indeed, we've had a lot of feedback from the health workforce to say that they feel much more included in the policy than they have in the past. And it does focus on that consumer lived experience to inform the severity assessment code rating of harm. So our legislation requires health and disability sector to rate the harm against serious adverse code 1 to 4, 1 and 2 being the serious events of harm, and they are the ones that are notified to the Commission. But that should be done by taking into account what that lived experience has been like for the consumer, because no one can account for that unless you listen to the consumer's experience. So there are 4 criteria, and when the health and disability services are audited against those ngā paerea standards I introduced to you earlier, they will be looking for these criteria to be met around this principle of consumer engagement. So, around open communication. So they'll be looking to see that providers work with consumers and whānau to understand the harm, that consumers and whānau are engaged in the review process, or at least it's been actioned that they can. And providers will enable access to support and education for healthcare workers who undertake open communication. And the last criteria is that open communication will be considered in situations where the system did not work as intended, even if no harm was experienced. So that would be, for an example, a near miss. So let us think a little bit more around consumer and whānau voices. As there was a need to elevate the voices of consumers, it was even more apparent after the research we got in 2019 from a Māori worldview. And that Commission research really did demonstrate that the experiences of Māori in hospital was really poor, and that was resulting in services that weren't being accessed because there was no trust or a lack of trust, and Angie talked to that in the video. So the lack of communication with whānau Māori, both intended and unintended, was highlighted in the research. And this was related to harm in itself being physical or spiritual, cultural or psychological. So consumer engagement significantly enhances our safety culture because it helps us understand a lot more about what the experience is like by involving those consumers, and they often have some of the best ideas for how this could be reduced in the future. So engaging them is really important in fostering transparency, building trust, and encouraging that open communication. Of course, it also is required from our legal compliance with the Code of Rights and Code of Engagement. So we also have consumers to participate in the learning review methodology. So this is the methodology that we teach. So we have moved away and encourage health services to move away from root cause analysis, unless it's very obvious that's appropriate and what they're looking at is complicated. But generally, because of complexity and using system thinking and human factors, we really encourage learning review methodology. And in that methodology, at the very end, are focus groups of people that help to make sense of what was going on at the time. Why did it just, what was so normal about the event? And really understand that work is done concept. And having independent consumers involved can really help to bring the consumer voice there. So it's not the consumer that experienced the harm, but consumers that are experienced at providing input into reviews. So when I first started at the Commission, actually, I led the maternal morbidity reviews for 3 years of women that were pregnant that went to high HDUs or ICUs. And we ran regional panels around the country, which were made up of multidiscipline teams. We had the consumer voice from the experience of going to ICU or HDU when the woman wanted to share it. Normally it was in a form of a narrative. But we also had, for the first time, independent consumers on our review panels. So these consumers were already well connected in their communities to consumer groups, so they're not bringing their own opinion, but that of the group. And they were working with the clinical governance already in maternity services, so they were well engaged in hospital services. They became part of the review panels. Initially, to be honest, there was some concern around having independent consumers in the panel, particularly from some of my medical colleagues, I can say. But once they came and they engaged with them, they didn't want to run reviews without them. And that was because they really felt that the independent consumers, and there were always 2 of them, really helped to break groupthink in the focus groups and the review panels down. They helped to challenge us in what we were saying. They challenged assumptions and bias, and they really helped us to understand opportunities for improvement. So when we run our workshops on learning review methodology now, and if we have people that are there that are really a little cautious and anxious about having independent reviewers being part of the focus groups, we encourage them to do as Amy Edmondson, that some of you may know. She writes a lot and presents on psychological safety. She talks about the importance of identifying your own vulnerability. Why do you feel vulnerable about having independent consumers as part of your review focus groups? And then really consider leaning into that vulnerability. We must be open to vulnerability, because that, by learning to lead into those hard discomforts, enables us to become more open-minded. And you can hear more about that in Amy Edmondson's Mindful Medic podcast if you want. So this is a lived experience of a woman who contacted us when we were still writing the 2023 policy. So it was in draft form, and she came to us because she had experienced a traumatic time with her newborn, and about 6 months later she was starting to ask questions, and she found out that in fact the hospital had reviewed her case without even seeking her voice. And she felt that because their voice were not sought, they really felt unseen, and they felt more harm, experienced more harm through not being able to share their voice. And when she read the draft policy, she really felt that it would give the opportunity to really enable the voice of consumers and whānau to be heard through a more robust and compassionate restorative adverse event process. And she was really positive about the 2023 policy. So we hope that's coming to fruition. Which leads me into restorative practice. So the policy introduces restorative practices and emphasises hōhō-torongo, which is peacemaking from a Te Ao Māori perspective. These practices prioritise cultural safety, psychological support and equity, ensuring the reviews are compassionate and inclusive. The goal is to address harms, to meet people's needs. So this is the harm experienced by the consumer and their whānau, the harm experienced by the health workers involved, to identify the needs of all of those people and how we can restore trust in each other and in the system and therefore promote healing. Restorative practice is a voluntary approach and there is a lot of work that is done before the parties all come together to meet together, and that is with a very skilled and experienced restorative facilitator. Some of you may have heard that New Zealand led the world in many ways in the application of restorative practice in the big mesh inquiry and finding opportunity to heal and restore people that were exposed to trauma from the insertion of mesh products. And hōhō-torongo, as I alluded to, is peacemaking from a Te Ao Māori perspective, so it complements restorative practice from the Western worldview. It's normally done at the marae, so the Māori meeting house. You can see it just behind the woman and her child here on the screen. It's normally facilitated by the elder, so the kaumātua, and sometimes it takes several visits in order to find peace. But it really brings an awareness that is opportunity to be proactive, to establish a relationship with people and to bring that hōhō-torongo into our health and disability system. So I'm just going to play you a very short video, just a minute here, around restorative and hōhō-torongo, but there is a link on the bottom of this slide on the screen that is to a 15-minute video around restorative and hōhō-torongo with an example of hōhō-torongo in the maternity event of harm. I really encourage you, when you've got some other time, to play that video and just see what you can learn from that opportunity.
I think the affinity between the hōhō-torongo pai and restorative practice is that both of them actually recognise that relationship is key.
So restorative practice offers the opportunity for healing, to restore well-being and relationships and trust following a harmful event in healthcare.
People are coming to a place that's safe. It enables them to be confident and be comfortable about sharing their experiences.
The most powerful element of restorative practice is listening.
It means genuine engagement in people's stories.
So that we can together come to some conclusions about the actions that would actually make things better.
For me, it's about healing relationships between people.
Patients who've experienced harm in the medical system, actually having their voice heard.
And an opportunity to listen, to learn and to respond.
Essentially, yes, it's whakapapa.
So our aim in reviewing is to create system solutions that allow people to do the right thing and therefore reduce the likelihood of harm reoccurring. In order to do that, we ultimately have to seek to understand the multiple perspectives. Everybody brings a different perspective. One should anticipate that when doing reviews of harm, but those different perspectives bring different insights and they bring different solutions. And it's really important to be able to see the world through all of those different experiences. And that gives us a better opportunity to engage with our consumers and whānau, to engage with the health worker that was involved in the event. But we also encourage gaining the perspective of other people that were around at the time. So, for example, if I was reviewing a harm event that occurred in birthing suite, one of the key people to talk to is always the healthcare assistant. They have a really good idea of what's going on everywhere. So we really work at gaining all these perspectives to form a narrative of the event and then to make sense of it through those sense-making focus groups. So before I finish with this presentation, I just want to take a moment to bring our mind to the importance of language and how language shapes our world and the ripple effect of words. Thinking about language is important here as we have discussions with people that were involved to gain their perspective. We need to be really aware of the language that we use. How we engage will encourage them to share more with us, be more willing to engage with us, and establish trust. The language we use as review facilitators and as key communicators with our consumers and whānau will become the language that they use. So if we use blame language, or if we use counterfactuals, such as the nurse should have noticed the deterioration, this will be the language that others will pick up, the language that they will use, and it's not the approach to reviewing that enables us to heal, to learn, and to improve. So we actively encourage consideration and reflection on the language that people use when we run our workshops and ourselves, and we're still correcting ourselves and we're still learning because it's really important that we just take that time to consider it. So instead of saying we're going to be doing an investigation, we say we're doing a review of a harm event. Instead of saying we're going to interview someone about their involvement, we say we're going to have a conversation with somebody, and we just try to be much more engaging and really cognizant of the unintended interpretation and the ongoing harm that we can cause people through the inappropriate and unintentional use of some words. So to finish today, I just want us to think about some opportunities. So consumer engagement is a powerful tool for enhancing system safety, fostering healing, and driving system improvement. And perhaps our approach, grounded in restorative practice and cultural responses, may be of benefit to you. By involving consumers in whānau and harm events, healthcare providers can gain a much deeper understanding, builds insight, builds trust, and creates opportunity. Often people say to us at our workshops and in the work that we do, we don't have time for that, Leona. We're too busy. We're really under-resourced. We're so constrained. And I do appreciate that. When I go and work as a midwife on the floor, I really understand how constrained we are. However, we also know that by taking time to hear and engage with consumers and whānau, we'll be better able to identify what their needs are and maybe meet their needs rather than having to find other ways to try and meet their needs, which in New Zealand means they often go to the HDC, and then we would get a complaint from the HDC and we would spend hours as a hospital writing a response to that complaint. So if we can move ourselves from being busy on the dance floor, so busy we can't see, if we can hop up on the balcony and see that maybe if we spend a little bit more time here, we can save a bit of time there. So we just encourage you to think about that opportunity. The policies and frameworks that we've got and that I've shared with you today do provide us with a robust foundation and meaningful engagement. And the use of learning review methodology promotes engagement with consumers, whānau, and all those health workers involved. And it shifts away from blame and shifts us to understanding through sense making. Your strategies align well with some of these, and there may be opportunities for future collaboration. Maybe together we can ensure that the voices of those affected by harm are heard, respected, and used to create some lasting beneficial change. Thank you very much for listening to me today. I will stop my slideshow. Here we go.
Leona, thank you so much. That was inspirational to hear about how you have immersed yourself in your culture, to learn about your background, and just around your approach to the policy. Of course, very interesting for us when we look at our policy development pieces. So thank you so much. And I know it's extremely late over there in New Zealand. And for everyone who's listening in, we just have a couple of questions, I think, from our side of the house for Leona. And she is going to close us out with one of those wonderful prayers. So do hang on if you have time. We won't keep you too long, Leona. I'm quite jealous really to hear about the multiple driving forces in New Zealand, really, and it's I mean, you speak so highly around the implementation around pieces, not least around no fault compensation approach and just the immersiveness into the culture. So I've much admiration for you. I love that you have consumers on the review team. And from my own experience in Ireland, we have had that with a couple of incidents, but we haven't really embraced that yet. How easy is it to recruit that? I suppose we're looking at developing our policy at the moment, so there's always writing it into the policy is one piece, but how does it actually work in practice to get those people on board?
Yeah, well, that's a good question. And I mean, to be fair, what I presented is how, this is how we want it to be. And there are some amazing pockets around the country where that works very well. And there are others that are still developing. What we have had before, and with the health reforms, that has changed slightly. We used to have consumer councils in all the hospitals. And so those consumers were independent, and often they would become and were the resource for having independent reviewers on those focus groups. But some, so for example, maternity, they have active consumers that are part of their clinical governance all the time. And so those consumers are involved as independent voices in the review panels. And there would be other services that may have consumer engagement as well that would perhaps use them in their reviewing. It depends how the governance structure is set up, but certainly in the framework of clinical governance, it is for active engagement with consumers and having consumer groups involved. And so those consumers would often be resources for independent review focus groups.
Yeah, no, that's really interesting. I suppose in Ireland we do try, with some of our committees and that to always have to we would refer to patient representatives on the group, but even from the incident management side of things, we have serious incident management teams where the kind of senior managers kind of reviewed kind of initial needs in response to the incident. And I suppose there's always a risk of groupthink then in terms of that decision making. So that might be something for us to take away. I think the probably last question from me, because there are a few coming in through the chat. I really like the empowerment approach for your consumers in terms of the defining of harm, because I think in Europe, so not just in Ireland, it has been focused on physical harm, but we've obviously referenced psychological harm now, but you've gone that step further, which I just think it's fascinating and again very impressive. And did I hear that correctly, that you measure or you look at the harm not just in terms of the consumer but in terms of their family and their community as well, or did I misunderstand that?
Well, I think we know from restorative practice that when a consumer is harmed, the ripple effect is great. So when a consumer is harmed, the family are harmed, and then that harm does ripple out into the community. Friends are harmed by seeing the effect on the consumer, on their friends, and then it does ripple out. And if you have the opportunity to have Dr. Jo Whaling come and talk to you about restorative practice, she would talk much more around that, about the ripple effect of harm, because often we've thought harm is really about the consumer's experience of harm, and we haven't thought about how they take that harm home and they talk to their friends and they talk to the playgroup when they drop the kids off, and then people start to think, oh, I'm not sure I want to have my baby there at the local hospital after listening to you. So it becomes, it just ripples out. So we just have to be more aware of that, because if we can find some resolution to that harm, then that consumer will then be saying, I had this event and it wasn't great, but I spent a lot of time working with them and I felt that, they identified what my needs were and I could have them met by being involved in a review and helping design how the service could be better. I feel comfortable. I could probably go back there now, so it's a different way to look at it, really.
No, that's brilliant, and it's kind of leading into Sheila's question. So her question was around restorative practice. I suppose Sheila was querying in terms of your approach to restorative practice, it's grounded in the Maori culture, or I suppose if whether it's grounded in there, you've taken a lot from the Maori culture. Do you have any advice for us working in a different culture?
So we have restorative responses. So we have restorative practice from the Western worldview, from the Western literature, which comes from restorative justice that you see in the justice system. So it's based on all of that theory and that knowledge. And then we have alongside it the Te Ao Māori worldview, the Hōhō. So we have both worldviews of restorative. So if you have a Māori family, they might want to have Hōhō and go to the marae. But if you have a European or an Asian family, they might want restorative practice from a Western worldview, the normal sort of restorative justice approach. So we have both complementary of each other.
That's brilliant, thank you. And Laura's we might have touched on already, just in case I missed anything, that it's again about involving the consumer in the review piece. So you mentioned that they have close links with their community, that they are there to represent the community views, not just their own. Is there any other criteria or characteristics that you consider when choosing someone to be on the review panel, such as previous education, previous career, and so forth, so that you get someone who can best contribute to the review?
Yes, well, when we did the maternal morbidity reviews that I alluded to for those 3 years, what we had there was we had several criteria that we would suggest that they responded to when they applied to be the independent reviewers. And one of those was that they were actively involved in the maternity clinical governance already. So they had a good knowledge about how the system worked. And then, yes, that they were well connected to community groups, because we didn't want to have a consumer that had their own worldview, their own perspective, but actually that it was much wider than that. So those things were important. And some, yes, some would demonstrate in that what their academic qualifications were, or where they worked, those sorts of things as well. But we want to be really reflective of the community. So if we could have, different reviewers, different women or different people, some might be academic, some might not be, that's absolutely fine, as long as they were well connected to a group of consumers was really important. And that we never just had one consumer, that they came together so they could support each other. That was really important as well. And normally they would meet with me as the chair of the review panel before we met, to make sure that they were comfortable, that they knew how to ask questions, or if they were concerned about things. So we could just make sure they were going to a space of comfort. And then again after, to debrief them, so to make sure that they were safe before they left the environment.
Oh yeah, that's really powerful, even that debriefing piece, and maybe that's something that we could reflect on as well. So a lot of positive feedback, Leona, not surprising. So Marcella, just thanking you for the wonderful presentation. And again, she just asked that at the beginning, you mentioned that the New Zealand policy is very much about the relational piece rather than the risk focus. And can you speak a bit more about that?
I think that was intentional, that we wanted to move more into relational. So that is about, bringing Te Ao Māori lens as well, because in the Māori worldview, relationships are essential. So they believe there is a relationship, like in the forest, all the different levels of the forest are related to each other. The ferns grow under the certain trees and so forth. Relationships are really important, and we need to just be aware that we can step into that space without being risk averse, without being worried about what the consumer might challenge us about, or what the risk of introducing someone into a space where they might raise a question that might challenge your belief or how you do something. So sometimes because of that risk, we don't enter that space, but we're like, we need to just be open to be relational and identify about risk, but embrace the opportunity that it brings to us. So in the past, we haven't involved consumers because we've been more risk averse about it, but we've moved into that space of being more relational. And certainly we've found in one of our big hospitals where they've worked really hard over the last year to engage with the consumers and whānau in the reviews, they have had less numbers of those being escalated to the HDC as complaints that haven't been resolved. So by having the consumer involved at the beginning and throughout the review and letting them share their experience and being involved in identifying improvement has met their substantive needs to many degrees. So really important to embrace that and not be worried about the risk it might bring to you as a person.
Yeah, it's so important, like, and it really resonates because obviously in incident management, it's always been about learning and improvement, but it is that relational piece, like you're so spot on. So thank you for sharing that. Cora had an interesting question as well. Again, thank you for the brilliant presentation. She was wondering if there are any strategies, frameworks, and/or best practices in partnering with underserved groups in health services with, she means, for example, people experiencing homelessness, vulnerable migrants, people who use drugs and alcohol or the like. Is there any insight you could share with us, Leona?
Yeah, I don't, at this moment in time, can't think of any specific frameworks, but definitely I think the important thing is to identify their context and where they come from. So our homeless people are homeless because of multiple situations that they found themselves in over life's journey. And we need to best be really aware of our bias, make sure that we identify our biases, which is why when we do reviews, we always have two people as facilitators to be able to call out each other's bias if we start to demonstrate any sign of that, which I think is really important. And I know that when we were involved in reviewing some of the COVID care and community work, we were involved with some of our vulnerable populations. So our former refugee group, for example, I ran some focus groups with them. And it was just making sure that we were in their space as best we can. So going out to where they reside and spending time in their homes and in their safe space. And with our reviews, sometimes when we meet with consumers, I know some hospitals, they go to the consumer's home, they go wherever the consumer feels safe to be. Asking a consumer to come into a hospital where they were harmed is the last thing that they really want to do. So identifying with our vulnerable people especially, where do they want to meet with us is the most important thing to do to engage and to build that trust in that very early on before we've even met, for them to know that we are aware that there are things that will be important to them that we might not know. So asking them from the beginning what we can do to be able to link with them and meet with them.
Yeah, certainly something we can learn from you. So again, it sounds like Abby had a great time in New Zealand, reflecting on the wonderful time and very recently over there, and very insightful to learn from you how you've approached the learning from harm events. Caro, again, just reflecting that it's really nice. Oh no, sorry, I lost my name. Orla, just reflecting again, the empowerment of including healing within the approach to incident management. So yeah, really positive feedback from our side. There's one last question I'll just give over to John. He was just wondering, could you expand on the higher bar for litigation? So I think it's certainly something that is quite prevalent in Ireland, and it causes, it's challenging for everybody. It's not what our patients want to pursue. Obviously they have a right to compensation, but it'd be interesting just for our audience if you just expand on that, please.
Yeah, so I still have indemnity insurance as a practicing midwife in case something was to happen. However, because of the ACC legislation, it's incredibly, someone has to really demonstrate absolute negligence on behalf of the health professional in order to bring a case against them. And when I talked to my work colleague who's a lawyer, she was saying, and she used to work for the HSE, that that's what makes it so different and so unique in New Zealand, is that there'd have to be very clear-cut evidence of negligence in order to bring a case against a health worker, because it's so protected by the accident compensation legislation. But as I say, I still have indemnity just in case, but it's totally different to when I was working as a midwife in the UK. My indemnity is quite different to there, where there isn't that protection from the ACC.
Okay, thank you. I suppose I'll just eat my words a little bit. I think it's probably right to give one of our patient partners the last question of the day. So Joe was just querying, in Ireland we have a role called the designated person. So generally when there's an incident or we require open disclosure, they're the person who links in with the patient and the family. So they're kind of their point of contact, support, and enable that communication to the person that's between the person that's harmed and the health service. Do you have a similar role in New Zealand? And if so,
Yes.
what training or support do they receive?
Yeah, so that is part of that open communication principle and those criteria that the services get audited against. The services have to demonstrate that people that provide the open communication, so the health worker providing open communication, has to have education and training alongside that. And so it's a similar person to what you described, Joe. So someone who is designated to be that continual liaison and contact. But I can't really talk about the different hospitals and how they provide that because it will be different around the country. But definitely they need to be able to demonstrate that to pass their audit when they get audited every 3 years.
Okay, yeah, I'll probably catch up with you about that audit piece. That sounds interesting from our perspective as well, because you know, there's an increased ask around assurance and things like that. But a bit like Jer says, a very insightful presentation showing how we in Ireland can certainly learn a lot from New Zealand. And I suppose there's the challenge to us. It's a similar population. We've got made good ties with you, Leona, so I'm sure we'll be liaising with you again in the future. We have a few closing slides, and if you can stay on for the final prayer from Leona, she's going to close out the session today. A big thank you from me to you, Leona, for making the time, especially so late in the evening. And we really appreciate it. So everybody will receive an email with a short survey for today's webinar. We really appreciate you engaging with that and giving us feedback. We always share it with our presenters as well. They do take the time bona fide to make time for us to share their expertise. So it's the least we can do, just to give them some feedback and for us to continue to develop our webinar series. As ever, you know our persuasive mantra at the end. If you haven't already, try to we'd encourage you to do your mandatory open disclosure training on HSE Land Module 1 for all your staff. And if you are staff working within the open disclosure space, we have the more advanced module as well, and we're liaising with all the regions really around the face-to-face training and that. So we've written to the REOs very recently about that, and we hope to support you and your trainers with regards to that. So I'll hand over to Leona now to close out the session. Thank you, everybody. Thanks to the team.
Thank you. Thank you for inviting me again, and I wish you the very best of a Thursday. So I'll close us with our karakia whakamutanga. Kua mutu a tātou mahi, ka tai te wā, mo te whakere te kete kōrero, e te kete whakaru, e tiki atu anō mā tātou, tau wherotia mai mātou katoa, o mātou hoa, o mātou whānau, e au ki te aorangi, hui e, tae ki e. Bye everyone.
Bye, thank you.
Goedemorgen, asu, goedemorgen.